quite made for it yet.
That's what Blake.
Okay, so welcome everyone, and this morning was scheduled as a potpourri. Let's go ahead and Nicole, you want to start?
Sure. So there's a large ulcer.
Yep.
With a tiny bit of epidermis, and then the inflammation seems to go deep into the subcu and maybe even into some of the, maybe that's fascia.
Yep.
Down there.
Okay.
So first thought I would be thinking like a decubitus ulcer of some sort.
Yeah, so there's some sort of big, deep, nasty ulcer in the adjacent skin. Does the collagen look normal?
No, it looks a little sclerotic or hyalinized.
Yeah, it looks a little sclerotic, hyalinized, little morphia-esque, if that's a word. Do you see any adnexal structures in the surrounding?
No.
Put that together with the dilated vessels. So you have this morphia-like sclerosis of the dermis, dilated vessels, lack of adnexa, and what looks sort of like solar elastosis, but it's everywhere, deep into the dermis, even down into the fascia. And we have some, not as prominent as they might be, but some fibroblasts. They're little gray, large stellate, perhaps. Hard, I think, just because we're seeing the edge of it. And you don't have as much edema here as you sometimes do, but chronic radiation changes.
Okay.
So the radiation changes include elastosis that's full thickness through the dermis, often in vertical columns in follicular fibrous tracts, large stellate radiation fibroblasts, resemble the fibroblasts in pleomorphic fibroma, vascular ectasia, and morphia-like sclerosis of the dermis. So, if this were mid-back, kind of just off-center, mid-upper back, anyone likely cause?
They got a cat.
Yeah, exactly. So prolonged cardiac cath, prolonged fluoroscopy is they're looking at your heart from all different angles. It all converges on one spot on your upper back. So a spot, basically they burn a hole in your back by working on your chest, multiple angles. So a upper back, just off midline, spot of intense radiation dermatitis. You'll see that's not uncommon. People come in and they have this spot on their back. That's post-prolonged
Fixes the
cath.
nostalgia, though.
Exactly. But if you have something, it's kind of a distribution like a notalgia paresthetica, but
Actually a rash.
looks like radiation dermatitis when you see it. Okay. Is that page there? Okay. I could just see your forehead above the eyepiece.
So this is a broad lesion. It looks like there's some sort of infiltrate in the dermis.
And the infiltrate appears to be composed of what kind of cell?
Maybe lymphocytes.
Maybe lymphoid.
And there is some pigment.
And there's pigment, and then these round pink
there's
things.
Savat bodies.
There are savat bodies and your reedy pattern.
And I'm trying to remember to give a name to it.
Kind of effaced. And your basal layer. Do you have a vertically oriented columnar layer at the base?
No.
There we go. So your basal layer is wiped out.
Yeah.
So you have squamatization of the epidermis with basal layer wiped out. You have savat bodies. You have a sparse band-like infiltrate. You have pigment incontinence.
I'm blanking.
No, it's fine. Anyone jump in?
Just a lichenoid interface.
So late stage of a lichenoid interface. So how fixed drug would be different potentially. You'd expect papillodermal fibrosis. Usually no savat bodies, but papillodermal fibrosis. Your pigment would be down around vessels, and your basal layer would not be, you wouldn't have the squamatization. So squamatization, savat bodies, pigment that's higher, hasn't gone down around vessels, sort of burnt out lichenoid dermatitis. So late stage of lichen planus, benign lichenoid keratosis, anything lichenoid in its burnt out phase. That's good. We can find the tissue. And in fact, there's a little one there as well. So yes, little cornoid lamellae and porokeratosis. Center of poro, remember, can look like absolutely anything. Look for the cornoid lamellae at the edges.
So, punch biopsy of a melanotic lesion looks like a blue nevus.
It's like a blue nevus, so why does it look like a blue nevus? Very good gestalt.
It's like my sister, so I recognize her. It's the spindliness of it, like the pigment that you're getting, the wedge-shaped.
So wedge-shaped, dendritic melanocytes, and it has its own sclerotic stroma that's different from that of the corneum, or I'm sorry, different from the regular dermis, with your condenser flipped down, and on low power, if you do diffraction, usually they black out pretty well, whereas your surrounding dermis is bright or refractile. That one's not shown quite as well as most do. You can also do it with polarization to show that if you're having trouble seeing that it has its own collagenous stroma there. Let's get ourselves back to 75.
So it looks like we're like compact horn on acral skin. In the middle, there's a bunch of pigment. Can't see. It's like some kind of acanthoma epi in the middle. I guess there's just a bunch of little nests there, just like a, and it's okay to have it floating up. Oh, those look sort of mildly evil. Kind of confluent in the middle, like MIS perhaps.
So,
But it's so small.
so it's small.
You
Acral
know what
clarks.
is, like, how is it bisected, right? That's like
Yes. Can I see the sheet to see the dissection report?
So you correctly said acral skin. You said it's small, well circumscribed. It ends in a nest. Small, well circumscribed melanocytic lesions that end in a nest are usually
Clarks.
benign.
That's benign.
And then Christina pointed out the reedy pattern. So where it looked confluent is because you've got a whorl in your dermatoglyphs, so that you have an oblique cut of the dermatoglyphs. If you look up at the corneum, you have nice tight little columns of pigment in the corneum. That suggests that there were nice tight little nests underneath despite the oblique cut, and goes with benign nevus. Very good.
So punch biopsy. Looks like a basket woven horn. The dermis, there's a patchy infiltrate. Looks mostly lymphocytic. A little interstitial infiltrate as well. Okay, periadnexal. Let's see. Ooh, looks a little more neutrophilic, perhaps.
Neutrophils and
Lots of eosinophils.
neutrophils and eos. How happy is your vessel?
Not very happy.
So you have an unhappy vessel.
Is that thrombus inside the vessel?
Marked thrombi. In fact, if you go back to the other vessels, marked thrombosis.
Looks like, I mean, Cururexis as well.
Yep.
So like another in the vasculitis range with a thrombus, maybe like septic vasculitis.
So vasculitis with thrombi, septic vasculitis, absolutely. Levamisole-induced purpura can be just thrombi or can be thrombi plus vasculitis. ANCA-associated vasculitis would be in your differential, especially Church-Strauss with the eosinophils. What else can give you a little bit of vasculitis, wedge-shaped infiltrate, lots of thrombi, lots of eos?
Give me an arthropod.
Yeah. And this one was just a tick bite. So tick attachment site. But that was an excellent differential. So wedge shaped with the vessel at the point of the wedge. Vessels that are unhappy with leukocytoclastic vasculitis, eosinophils, thrombi, could be septic, could be Church-Strauss, could be arthropod.
What's the buzzword for like cryoglobulins filling the vessels? Doesn't it look like something special?
Jello jigglers.
Okay. Probably missing the
Usually no vasculitis.
Okay.
So cryoglobulinemia mixed looks just like a postcapillary venial leukocytoclastic vasculitis. Monoclonal cryoglobulin are jello-like deposits in the vessel with in the absence of vasculitis. Okay, Rachel, what do you think?
Okay, so I've got a broad lesion. It looks like there's some sort of nest maybe in the...
So broad lesion, junctional nests. Are the nests similar in size and shape to one another?
There's some variation.
There's variation. Are they equidistant from one another?
No.
And areas where there are bizarre sausage-shaped junctional nests?
I'm going to go with yes.
You're going to go with yes on that?
If you say so. And there's definitely some interface inflammation.
Junctional confluence, consumption of the epidermis almost up to the corneum.
So is this MIS?
So MIS, and then how about these nests here? Do you see any evidence of maturation or dispersion in those nests?
No.
So then invasive.
Yes, it's invasive.
Yeah. So, the MMIS, which is overlying, catches your eye, but then those dermal nests were also invasive focus. So as you said, very broad. Areas where poorly nested melanocytes predominate over nests. Nests are not similar in size and shape. They are bizarre shapes, not round to oval, but very odd in shape. They are not equidistant from one another, not regularly spaced. There's consumption of the epidermis, effacement of the epithelium. It's on sun-damaged skin. Predominant pattern is at the DE junction, so Lentigo maligna type of in situ with then focus of invasive melanoma. Very good.
So a dermal infiltrate looks like, is that mucin in it?
There is definitely a steel gray myxoid stroma. with a branching alveolar glandular structures.
Was it a mixed tumor?
Like a mixed tumor, correct. So, mixed tumor, you can have small tubular type, or more commonly the branching alveolar type. So this is branching alveolar. You have sweaty deposits in the ducts. Your stroma has fat, as well as having myxoid areas. Not quite to the point of cartilage, but it is that steel gray of a chondroitin sulfate. So kind of a cartilaginous gray.
So we had a dermal nodule.
Dermal nodule. And you're in upper year, so it doesn't have to be a chapter we've covered so far.
And this is kind of, my first thought was like something like from a metabolic chapter, like gout or oxalosis.
Something metabolic chapter like gout or oxalosis. So do these crystals look more feathery like gout, or more of a four-leaf clover pattern?
The latter.
I'd say the former.
It
was a total turnabout trip. So the four-leaf clover is what oxalosis looks like, whereas this are really feathery crystals running in groups in different directions. So. But you did nail it on scan as metabolic disorder, and gout was the first thing out of your mouth. So you get credit for that.
Way to go.
We'll stop at the difference.
No chapter required.
Okay.
And, you know, in real life, they do have a nasty habit of coming without the chapter attached. And on exams, too.
So, I see like a lot of, looks like an infiltrate in the dermis with some pigment incontinence.
So infiltrate in the dermis, pigment in the dermis. At the junction.
And so like lining of melanocytes maybe?
Lining up with melanocytes, and they are involving...
Eating away at the basal layer.
Yeah, and they're up in the arch
Mm-hmm.
instead of being at tips and sides of rete.
Something bad.
So something bad. So something bad melanocytic.
Yes, like invasive melanoma.
Like invasive melanoma, and in the dermis you have this parallel theque pattern, these long nests parallel to the surface, which is a very common dermal pattern in melanoma. So just big, ugly melanoma.
So it's kind of looks like you have a little epidermolytic acanthoma.
So a little epidermolytic acanthoma, that's exactly what it is. So EHK, epidermolytic hyperkeratosis in a little cup-shaped acanthoma, often an crateriform architecture reminiscent. This one's maybe less crateriform and just acanthotic. So an epidermolytic acanthoma, what's the most common location?
I guess that.
Scrotum. Scrotum is like 90% of them. So the patients come in, and they, and sometimes you, also think that it's condyloma, and obviously important that it's not.
See a busy dermis, a little bluish.
A busy dermis.
Kind of has an interstitial GA pattern.
Like an interstitial GA pattern.
Except for those neoplastic cells there.
Except for the neoplastic cells.
man.
So what
Lining up
is
like little Indian.
so lining up in a single file array with nuclear molding, hyperchromasia. So this is
Metastatic breast.
metastatic breast. So busy dermis, interstitial GA-like pattern. Look closer at the cells. If hyperchromatic, in boxcar fashion with nuclear molding, that is metastatic breast.
So there's definitely kind of irregular hyperplasia or acanthosis. There's confluent para as well.
So confluent para and little bits of serum,
Yeah.
probably.
Maybe a little bit of wedge-shaped hypergranulosis in a couple of the areas, and then it looks like there's kind of that dermal fibrosis and
Yep.
a little bit of sponge.
So a little bit of spongiosis, dermal fibrosis, so papillodermal angiofibroplasia with vertical streaking of collagen. So put all
And then
that
it
together.
looks like LSC.
Yeah, LSC, and there's definitely some serum and active sponge, so like a very chronic scratched dermatitis. Very chronic scratched or rubbed dermatitis. So changes of Lichen simplex chronicus, which would be the wedge-shaped follicular hypergranulosis, the irregular acanthosis, and the vertical streaking of the collagen in the papillary dermis. And then still active spongiosis and serum, telling you it is a scratched, rubbed dermatitis.
There's kind of a nodular dermal infiltrate. Looks like it's coming off of the epidermis, maybe,
Yep,
with pigment. I'm thinking maybe like a nodular BCC.
like a basal cell. And the only thing I disagree with is rather than nodular, I'd say this is superficial.
Okay.
These are like garlands hanging at the holidays, hanging off the epidermis. Tell me about your margin.
Clear. Well, actually,
So is that normal dermis?
no.
Or is that tumor stroma?
Tumor stroma.
If it's tumor stroma to the edge, that counts. Okay. The other piece to look at is this piece, where you have no tumor. All you have is the stroma. That you have to recognize on a biopsy too.
Okay.
It's not normal dermis. If the question was rule out BCC and that's what you're seeing, that's basal cell stroma. So you just have to cut deeper to see your basal cell there. Basal cell stroma is, you usually have some fibrillar collagen, a lot of edema. You have no reticular dermis. It's all pushed downward, displaced. There's usually vascular ectasia and a sparse lymphoid infiltrate. Looks different from the compact red fibrosis of an actinic keratosis or melanoma, and it's recognizable. And most important thing is if it extends to a margin, that counts as positive. So irritated Septic. You see the horn cysts. You see clonality. There is spindling and squamous eddies within those clonal nests. There's pigment. There's inflammation. So you could have legitimately said an inflamed clonal irritated seborrheic keratosis, ISK is fine. It's all of those things, and these, as the epithelium can look kind of wild, sometimes they're frequently overcalled. But just recognizing the architecture at scan is key. almost infectious. So what kind of pattern do you see here?
It's very follicular. It's, I think you're pointing at
Or
neutrophils.
probably more newts, yeah. Neutrophils in your epithelium.
It's like glassy and degenerated.
Yeah, pseudoepitheliomatous hyperplasia. So
Okay.
PEH with pus,
So the mnemonic is here comes big green leafy veggies.
and that stands for
Histo,
halogenoderma,
halogenoderma,
chromo,
blasto, green,
granulum inguinale,
leafy is
leash,
leash, and then veggies is vegetans.
and pemphigus vegetans. Important because a lot of those things are infectious, but halogenoderma is not infectious. Pemphigus vegetans not infectious, so you don't want to miss those. It could also just be a suppurative folliculitis with pseudoepitheliomatous hyperplasia. Down in the dermis, it's looking a little different because you have palisading granuloma with neutrophils in the center.
So that makes you think of it more being like a fungal or something in etiology, like it's trying to block it out, than just a folliculitis. Is that what you're saying?
Yeah, so
Okay.
raises the possibility of invasive fungal infection. Sometimes those neutrophils will get to the point of a stellate abscess inside of a granuloma. That gives you a little bit different differential cat scratch, LGV, atypical mycobacteria, tularemia, sporotrichosis. So you've got to run 2 parallel differential diagnoses and work through all of those possibilities for this. And this particular one grew atypical mycobacteria. Which means you nailed it pretty much at scan when you said looks like maybe something infectious.
Simplex.
I think I'm microorganisms.
I mean, there's like some superficial inflammation. There's a little bit of kind of pretty regular acanthosis of the epidermis, it looks like. Looks like there are lymphocytes with some vacuolar change.
And
Some of them are,
and the pattern, is it holes out of proportion to lymphs, or is it more like a lymph in every
I
hole?
would call it a lymph in every hole.
So lymph in every hole pattern, what's your differential?
So MF, and then the plebes.
So MF, pityriasis lichenoides, early evolving stage of a benign lichen or keratosis. And this one, what are you seeing above the postcapillary venial here?
You got your potbelly pig sign there.
So you have pigment, but you also have
Fibrosis.
papillodermal fibrosis. Suggests that this is something subacute or something more chronic.
More long-standing.
So a more long-standing thing with epidermotropism of lymphocytes, lymph in every hole.
I'm going for MF. Let's send this thing to Mayo.
So probably mycosis fungoides. Very good.
Some big shave biopsy. There's a like prominent horn, kind of loose, flaky. Let's see. There's a couple areas in the epidermis, like intraepidermal blisters or spaces. I don't know. Maybe some acantholysis. Some larger epidermal cells. I mean, that looks like a pilar. It's a pilar sheath acanthoma a little bit off the hair follicle or large cell acanthoma, maybe.
So there's certainly large cells, right? So composed of large cells budding downward from the epidermis, extending along the outside of hair follicles. The porokeratosis is a little bit large, like the cells are. And is acantholysis.
Is this viral?
Well, I'd say these are kind of atypical keratinocytes.
Mm.
And
Okay, so is this like squamous situ, maybe?
yeah, or just acantholytic actinic keratosis. So AKs tend to arise from the basal layer. They often bud downward.
Okay.
They tend to run along the outside of follicles, whereas Bowen's replaces the entire follicle. They often have a red and blue horn with the compact parakeratotic horn interrupted by columns of blue lamellar stratum corneum, which arise from the hair follicles, which remain intact. It's usually not quite full thickness. The epidermis matures at the top, but the bottom is atypical, and then you got acantholysis.
So it looks like I've got a lot of adnexal structures, like maybe I'm on the face or the scalp.
Lots of adnexal structures. So if you go over here, how big are your hairs?
Large.
Yeah. And if you go in the middle, how big are your hairs?
Very small.
Very small. And lots of
Spacious structure.
lots of sebaceous. So this is probably hair-bearing skin, right, with big
Yes.
terminal hairs. Where are all the big terminal hairs in the center?
I don't see any. Is this like an organoid nevus?
You are correct. Organoid nevus. So it's broad, it's bald, it's bumpy, it's bubbly, right? So broad, bald,
Nevus
bumpy,
sebaceous
bubbly.
of Jadson.
Nevus sebaceous of Jadson. So nevus sebaceous of Jadson or organoid nevus. This is probably right around puberty where it's just starting to get a little bit acanthotic and bubbly. The sebaceous glands start to appear. In young childhood, it's just tiny little pilar germs lined up. Around puberty, they start to become sebaceous. You start to see some apocrine units, and it becomes more cerebriform. So broad, bald, bumpy, bubbly is fully developed. Broad, bald, less bumpy, less bubbly is prepubertal.
So it looks like pink cells hanging off the dermis, so maybe like a poroma.
So, this
For
one's
epidermis,
more exophytic rather than endophytic. And we'll actually, because we haven't done this chapter yet, I think, let's skip to Brian and then we'll come back.
This one looked like it had some viral changes.
Yeah.
I thought this was just like maybe a wart, condyloma.
So,
Lots of little like EDV changes, kind of those bluish.
so I'd say definitely wart. When you have a compact corneum and it looks like you've taken a little cookie cutter and cut round to oval holes in your corneum, like up in this area, that is typical horn for a wart. There is often thrombosed blood within the vertical tiers of porokeratosis. The porokeratosis is distinctly round rather than being flat. And then these are coilocytes with vacuolization and coarse hypergranulosis. I don't really see the foamy blue so much of EDV, but definitely wart. Agree with you there. Okay, so Blake, how about this one?
So looks like a reticulated pattern off the
Definitely a
epidermis.
reticulated pattern off the epidermis. And what color is it predominantly?
Mostly blue.
So I'd say
Meh.
similar in color to your epidermis, right?
Mm-hmm.
but then you definitely have some more bluish tips. So I'd say it's more like pink anastomosing strands, blue buds.
Infundibulocystic basal cell.
So infundibulocystic BCC radiates outward from a central follicle-like opening. This is broader and is anastomosing bands and has a prominent fibrostroma in between. So Fibroepithelioma of Pinkus.
Very good.
Some large terminal nodules.
Large nodules and
Probably malignant.
so probably something malignant. Go higher power, and there are lots of mitoses. Sheets of these atypical cells, and trying to get a good area to show you. Areas that are spindled. That's not as good as some, but you can make out a little bit that the nucleus is on one side and you have pink cytoplasm next to it. That's what's referred to as a rhabdoid appearance, like a rhabdomyoblast, where you've got a nucleus that's eccentric and a blob of pink cytoplasm next to it. So a little bit of rhabdoid morphology, sheets of highly malignant cells.
Myosarcoma.
Yeah, it's actually that's a common pattern for melanoma, to look rhabdoid like that when it's metastatic. So just a huge nodule of melanoma.
So superficial and deep infiltrate, it's definitely around the eccrine glands. I don't really see any increased mucin. There's a little bit of increased spacing.
But having a little something around eccrine gland, superficial and deep, makes you at least think of lupus as a possibility. Tell me about your corneum.
It's kind of flaky.
So that's basket weave. This is compact.
It's more, you think of tinea when you see this.
So basket weave on top of compact, you always have to at least look for tinea. Tells you that it's something subacute. It's been about a week that it's been there. And that pattern of basket weave on top of compact red, really common for tinea, which is what this proved to be. Go a little higher. And you see a little white space there in the corneum. See that little circle there?
Mm-hmm.
At the junction between compact and flaky?
Yeah,
Yeah.
right
Right in
Nice.
there.
Oh, yeah. Caught me action.
And that's often where they live, is they typically live within that compact corneum, sometimes at the junction of that and the overlying corneum, more commonly towards the bottom of the compact corneum. But anywhere in that compact layer is where they can be well done.
Cartilage.
Is he going to do it? You want me to go? Okay. If you have key,
And
Maybe pseudocyst to the auricle?
that is exactly what it is, the pseudocyst of the auricle. Well done. So you have cartilage, and then the cartilage degenerates, and you have myxoid material in the middle, and then you only have half of your cartilage because the other half has fallen away. So you have a pseudocyst of the auricle or boxer's ear. Your sister slaps you up the side of the head, and you've got you get a degeneration of the cartilage,
Same
and
as cauliflower ear wrestlers.
yeah, same thing. Cauliflower ear, boxer's ear, nasty sister ear.
Based on how this is cut, I'm thinking that they want an alopecia.
So we're looking at transverse sections of a punch, which commonly is how we treat alopecia.
Hair density, at least in this piece, looks okay.
So hair density looks fine.
There is kind of pigment casts.
So there are pigment casts in the hair channel, and
there's a little bit of inflammation on that other piece.
what kind of hair is this? Do you see an intact hair
No,
in it? And your cuticle is kind of,
ragged.
yeah, and it's kind of in a weird shape that it's collapsed, and here's another one.
Mm-hmm.
And you have some individual necrotic keratinocytes. So is that a growing anagen hair? See all these dead red keratinocytes in there?
It's not really growing.
There. See all your dead reds in there?
Mhm.
So it's not a growing hair. These are all, and it's not a resting telogen hair either. These are all catagen. So numerous catagen hairs, pigment casts in the follicular channel. What's your differential?
Oh, I hate alopecia. I feel like trichotillomania.
So trichotillomania, absolutely two other things that can do that. So numerous catagen hairs, pigment casts, there are three things in the differential, and only
AA one
three.
of them?
Alopecia areata is one. Anytime you say AA, you
You
have
think
to
syphilis.
say syphilis. That's all three. So, and you are correct. You love alopecia because it's so simple.
Alopecia hurts my head.
It's so simple. You have numerous catagen hairs and pigment casts that can only be three things, right? Alopecia areata, syphilis, which can do everything AA does, and trichotillomania. So now you're going to look to see in the vertical sections, do I have any lymphoid infiltrates around the hair bulb, eosinophils around the hair bulb, pigment within the fibrous tract remnants? Those would all suggest AA or syphilis. We don't see any of those things. And the outcome was this was trichotillomania.
And traction, but not old traction, but new traction.
Traction looks similar to trichotil. That is correct. So we should say trichotil/traction. Let me say that.
There's some sort of pigment here in the dermis.
So some sort of pigment here in the dermis.
Very dark.
Very dark. So where you might think could be tattoo pigment or could be melanin. It's definitely brown. It's non-refractile, so it's not hemosiderin, so I'd say it's probably melanin. Many of the cells are dendritic. So a local deposit of heavily pigmented dendritic melanocytes on a scalp. First thing you look is to see, does it have its own stroma? It's not jumping out at me. If it doesn't have its own stroma, then you're in the realm of what's called pigmented epithelioid melanocytoma. Some of those behave as melanoma, dendritic melanoma. Some of them behave as nevi of Carney's complex. So it could mean that the person has a huge undiagnosed atrial myxoma if they have Carney's. It could mean this is going to behave like melanoma and metastasize. So PEM, pigmented epithelioid melanocytoma, is kind of a catch-all for something that looks similar to a blue nevus, heavily pigmented, dendritic, but it lacks its own stroma. Those are either going to behave like an epithelioid blue nevus, which is a marker for Carney's complex, or behave like melanoma. And horse melanomas in horses are dendritic like that, so it's sometimes called equine type melanoma or animal type melanoma. If there's a question about the stroma, you can polarize. And I'm honestly not sure if I'm seeing distinct stromas. So this is one where you really would worry about the possibility of Carney's complex and of equine type, animal type melanoma. So anything that looks kind of like a blue but lacks stroma is potentially trouble.
What about blue nevus like metastatic melanoma?
Blue nevus like metastatic melanoma, those would be equine type. They would look like that. So that whole term blue nevus like melanoma is equivalent to equine like melanoma. They show usually BAP mutation superimposed on a background of GNAC mutation. So GNAC mutation like a blue nevus, but on top of that, BAP mutation. BAP on top of BRAF behaves benign. BAP on top of GNAC behaves like melanoma. In the future, all of these things are going to be omas of various sorts. You already have BAPomas and ALK-omas, and they become, at this point, they're starting to be just immunostains. You have an IHC for BAP, you have an IHC for ALK. So these are going to be commonplace in the lab because by identifying the mutations by IHC and the pattern, you know what its behavior is going to be. And do those blue nevus-like melanomas, can you do FISH on them? Well, you can do it, but it doesn't help, right? Because they distinctly do not delete 9p21 or any of the common things that are deleted in ordinary melanomas. Their mutations tend to be on chromosome 3, and they're not picked up in the FISH assays. So it's one where simple pattern and immunohistochemistry may be much cheaper and superior than a $5,000 FISH, which you're not fishing for the right lesion. Like a reticulated seborrheic keratosis. You are the king of sebs. Very good.
Fishing for the right lesion. No pun intended.
There was the pun was entirely intended.
Puns are always
Yeah. And the worse it is, the better I like it.
This looks like a neoplastic lesion coming off the epidermis.
Okay, and what kind of neoplastic?
So it looks like a squame.
It's forming keratins, so it's squamous, and so that's absolutely so. How well differentiated?
Since it's making the squamous eddies and it's like encapsulating itself, I would say it's well differentiated.
So this one I probably put in the moderate. So poorly differentiated doesn't keratinize at all. That would be anaplastic or spindle. Well differentiated is pretty glassy, looks like surface epidermis.
Okay.
This one, they're large hyperchromatic cells, and focally they're still making keratin. That puts you in moderate.
Okay.
We have like some crusty junk up top, it looks like.
Some crusty junk up top. So is your corneum holding together or is it coming apart?
Negative, apart.
What do you call an apart corneum clinically?
A scale.
Scale. And almost all scale is parakeratotic, but here you have no parakeratosis. What's your only non-parakeratotic scale?
I believe it is the furfuraceous?
The furfuraceous scale of what?
Jonathan.
I was thinking the condition.
Oh,
Although Yadison is the correct answer for most other things. So like TV, so that junk that you saw there, you now know is tinea versicolor. So you have definitely a scale, but it's a non-parakeratotic scale. Your only non-parakeratotic scale is that of tinea versicolor. That means that amphiphilic crud up there must be TV organisms. Okay, that's it. We're out of time. At the meeting that I was at, Polivog gave probably the best lecture that I've ever heard on the state of the art of what you can do immunohistochemistry and all of the evolving data on melanomas and how, based on H&E patterns, you pretty much know what your differential is in terms of mutations. And there's no question, within the next 2 to 5 years, it's going to be just standard of practice that you will be doing IHC stains for these various mutations like we started doing for BAP, because it will define the different melanomas and define their behaviors. And for a lot of these, CGH falls flat on its face and FISH falls flat on its face, but you can identify them on pattern and know which mutations to assay by IHC.
Is it typically loss of?
It's typically
like
lost.
With that?
Yeah. So it's typically something that's lost in them. And
Is the lab the only place that's doing it right now?
no, in fact, he gave a listing.